everyone, this is Hafsanjam, and in today's episode of The Y Factor, we are very honored to have Dr. Rajesh Kumar Reddy, who is a distinguished and a renowned orthopedic surgeon. And his career is packed with groundbreaking achievements and life-changing surgeries. From handling the most complex fractures to pioneering the cutting-edge technology in orthopedic, Dr. Rajesh's expertise goes beyond the operating room. And what makes his journey different from the rest is his deep understanding on the overall bone health and why bone breaks. And we're also going to discuss of how our modern lifestyle is creating a havoc on our joints and bones. And additionally, we are also going to talk about the incredible journey of the orthopedic and the future of orthopedic with the rise of the AI. So with this conversation, we're going to ask every why of every question of a common man, and we're also going to discuss the most complex cases that doctor has handled that has hardly came into the light. Thank you so much for joining us today, doctor, and I'm really honored and privileged to have you today, because this conversation is something beyond just getting to know your journey, because personally it's been an amazing time knowing you, because you're someone that actually, I don't know if you know this, but you treated me a few years ago, and a lot of my loved ones were also someone who got treated by you, and we just don't recognize you as a doctor, but also someone who's very empathetic towards his patients. So I think that's something that I would really take away from today, because irrespective of whatever profession you're really known for, obviously the best of your work in the field, but also how patients remember you as the best of the doctor they come across, right? And we're very happy once again. And so Dr. Rajesh, let's start from the very beginning. Okay. So how the kid of Rajesh Kumar Reddy was, what were his aspirations, and how did medicine happen to him, and where do you come from, where were your origins from? So yeah.
Yes. Hi, first of all, thank you so much for having me on your show. Right, those are very great words about me. Fine. So to start with, I come from a place called Puttaparthi, right, and I've done my MBBS from Khammam Medical College, Mamta Medical College, in 2001, 2002. So as a child, I was really excited about the human body, how it works, and other stuff. So I was more tended towards science, right? So it interested me a lot, how the human body works and stuff. So that made me, go into the profession of medicine, MBBS. So I got my seat in Mamta Medical College, right? So in that MBBS journey, I have learned a lot. I've learned a lot of issues. Yes, one thing, hard work is very much important in that, right? Being sincere towards your work. It was a tough job also, 5.5 years of medicine, and your internship was also for 1 year. So then during my internship, I used to look at patients with fractures, right? Who have a road traffic accident or a domestic fall at home, and literally they come in a wheelchair or a stretcher, they're not able to walk, and a lot of pain and stuff. Then I've seen my professor operate, and next day they're sitting, and probably after a week or so they're on their legs and walking with the help of a walker and stuff. That really excited me, right, to come towards orthopedics. Okay, so my professor inspired me a lot to join the orthopedics. Then I joined orthopedics in 2009 in Vaidehi Medical College, Bangalore, right? So that's a 3 years of your course, masters in orthopedics. So there I was, 3 of my professors were there in 3 units, right? One was into joint replacement, one into arthroscopy, the microscopic surgeries, what you do, the ligament repairs and stuff. And one chief was into trauma, right? So initially it was trauma which I was more interested in. Basically any orthopedic surgeon, who joins first year of their post-graduation will be interested in trauma. So once I have done my masters in Karnataka from Rajiv Gandhi University, Vaidehi College. So post that I had more tending towards joint replacement. Okay, so I've learned my trauma well from there. So then I pursued my senior residency in Puttaparthi Sai Baba hospital from Puttaparthi, where I was actually born in that hospital, the general hospital. So I thought, why don't we start our journey from post-MS from the same institute. So it was really an honor to work in that hospital. So just to brief you about that hospital, is totally free of cost, with a world-class healthcare. Surgeons come from all over the globe just to do service.
That's great.
Right. And even they have a very good software which is related to orthopedics and all the other departments, where it is totally paperless, right? So a patient comes with a registration ID and you have all the data in the system which is in front of you, and you order an X-ray and the X-ray will be done, it will be pushed into your system. Right? So patient need not carry anything. Then you prescribe and you just tell him to go to the medical shop, where he goes and just get the medicine. So not even a single penny has been cost to the patient.
So is it like one of a kind hospital in this country, or like?
There are such kind of service hospitals, but yes, Puttaparthi Hospital definitely stands apart from.
That's amazing.
So not even a single penny they charge you, and they provide the best of the healthcare services. So then I went to that service motto and stuff. From there, I've done my fellowship in joint replacement and arthroscopy, the microscope what we do from Ahmedabad, Gujarat, under a renowned surgeon called Dr. Prathamesh Jain. Then I've come to KGH, King George Hospital. So I was married in my post-graduation days. And the second year of my MS, I got married. Her name is Kavya. She's an interior designer. Right? So I have a kid also. Her name is Aishwarya. She's in 3rd standard right now. So then I came to KGH, where there was a posting for me. So I've done it for 1 year in between. From there, I joined Queen's NRI Hospital in Visakhapatnam as a consultant. So I've been there for around 4.5 to 5 years. From there, I mean, after that, it's your practice what you build upon. So whatever I learned from my seniors, from my guide, my practice, what I've done this 15 years altogether. Once you put into your practice, then starting it's difficult. You assess, you do a surgery and everything. The patient comes to you, says everything is fine, doctor, I am good and stuff. Even you feel, is he good? Is he fine? Have I done the best of my job or not? Right? So as things went by, the patient reviews came back, and patients used to, used to come and say, thank you so much, doc. You made my day. My mother, it was fractured, and I'm so happy that she's walking right now. From there, I got an opportunity to work in Apollo Hospital. So once an opportunity from Apollo came, I was very much excited. Probably at the age of 33, 34, they called me to Apollo Hospital, which I felt very much privileged. As you know, Apollo is the one of the best corporate hospital in India, having 72 hospitals across India. So there I worked for another 4.5 to 5 years in Apollo. Then there is a new care branch which has started in Visakhapatnam. So they promised the orthopedic robot, which is already trained in robotic joint replacement also. So from there, the journey started from MBBS, then into orthopedics, fractures, trauma, arthroscope and everything. Then since my thesis work was also on knee joint replacement, so always I had this kinking towards this knee joint replacement and hip replacement. So from there, since the hospital here has started and they wanted us to head the hospital, so I formed a team of 3 doctors, myself, Dr. Srinivas and Dr. Santosh, SRS team what we call. So then we joined in Care Hospital. It's been 1.5 years. So we have orthopedic robo here, and I personally take care of the joint replacement surgery.
So how does a day in the life of the orthopedic surgeon looks like?
So generally the day starts very much early in the morning. So as surgeons, being any surgeon, be orthopedic surgeon or a gastro surgeon, we start our surgeries early in the morning, say around 6:30, 7 o'clock. So every day we have some 2 to 3 surgeries. We divide it amongst ourselves. So I go for replacement, Dr. Santosh goes for trauma, and Dr. Srinivas into arthroscopy. Right? So once the surgeries are done by 9:30, 10 o'clock or something, so there are some complex surgeries which requires 2 or 3 surgeons. So we assist our colleague in the surgery so that we can easily get out of the situation, probably do the surgery a bit faster. So once the surgeries are done, by 10 o'clock, we are in the OPD, okay, to take care of our OPD patients. By 3 or 3:30 in the evening, once the report comes, the x-rays come, we look after the patients, and where we operated, they come for suture removals. Some new patients with some new problems, we try to diagnose them, write some blood tests, get some x-rays done, try to diagnose the condition. Some people we just treat with medication, some might require some blood tests. So by 3 or 3:30, we'll get the x-rays back and stuff. So by 4, we are done with the job. But if the list is more, if the surgeries are more, then we again start operating at 3 o'clock or 4 o'clock. Okay, it happens probably weekly, once or twice. We do operate in the afternoons also. So by 5:30, we are done with the day. Then on a personal basis, after 5, I go to the gym. I daily have a workout schedule. So 6:30 I completed. So by 6:30 I'm in my clinic. So in my clinic, from there it probably 9:30 or 10. Then I call it a day. So I take care of my surgeries, I take care of my OPD, I take care of my health, and I take care of my OPD also.
Okay.
It ends over there. And weekend is a strict weekend. So I need to take care of my family also.
Yeah.
So by Saturday evening, by 5:30 we call it a day. So Sunday we're generally off, but emergency is 24/7.
Got it.
So one day I am on call, next day Dr. Santosh, next day is Dr. Srinivas. So that day we see to that we are in town and available. We need to take night calls also because we get emergencies. Then we have our senior resident who is a post-MS. Then we have a fellowship also. After MS, we teach our juniors in the field of orthopedics. Like right now, we have a trauma fellowship. So whatever fracture cases come. So after their MS, after their post-graduation, they come to us for a 1-year fellowship program, which I have done in my previous years. So we teach them. It is through the Orthopedic Association of Andhra Pradesh. So we have got the fellowship. So they will be on call. So first the senior resident, then the fellow. Then if it is not been managed by them, then the call will come to us. I'm third on call. So some emergencies do come where the bone is out of the skin and stuff, and some multiple injuries where they require the surgery in the night itself, right? Some fractures where it will compress on the blood vessels or the nerves over there. So that kind of surgeries we need to do it on an immediate basis. So then there is no time. I mean, I cannot say I'll only work this hours, that hours. So we go for a surgery. Sometimes we start at midnight, 12 o'clock or 1 o'clock, probably till 4, 5 we are operating. So that's how it happens. And weekend, Sunday we generally take off. But again, the emergency is running 24/7. Sunday we don't see any OPD, no outpatient basis. It's only the emergency which we look after. And our surgeries start in the morning, early in the morning.
So doctor, so just a follow up for that. So let's say if I ask you, what is the one good thing about the work and the profession you're right now, and what is the one challenging thing that is for you right now? So if you have to answer that in a one sentence, what would that be?
Okay, so one sentence would be a difficult thing because there are a lot of challenges. There are a lot of challenges. As I told you, the time, there's no specific time, you cannot say that I cannot attend an emergency. If the surgery goes for a long, I can't say that I can cut it short, I can come and operate. No, that doesn't happen. But one good thing is you have an immense satisfaction.
Got it,
Once you operate, it comes well, you see the patient walking, you see them saying thank you. It's not about the money. Many people do get some gift hampers, some chocolates, some sweet or stuff. We feel very nice, some people from the rural areas, they get some honey saying that, sir, this is from the Desi one, it is unadulterated and stuff. Some get some nice toys for my daughter also. They ask, what do you do, sir? How many people have? So that gives us very much happiness. You cannot buy those things. And then I have a soundless sleep. As a surgeon, as any surgeon, the surgery and the surgery, the patient satisfaction gives immense pleasure and good job satisfaction you have at the end of the day. Yes, the stress is huge. because we operate and there is something called a CM, which is an X-ray machine. We operate under that and we stand for hours and hours. So we need to take care of our physical health also. We tend to get these varicose veins and stuff, use some stockings. And being an orthopedic surgeon, we drive nails into the bone, put screws into the bone. It requires a lot of torque, physical strength. So I generally take protein intake a lot, to keep myself healthy and see to that I can get my job properly done.
Got it. So doctor, so how many surgeries have you performed in your tenure of serving as a doctor, and how has your approach changed over the years? Let's say when you're starting it off, what were the things that you learned right now, and let's say if someone is also starting it off in their orthopedic surgery journey, right? So now you as a renowned and a very specialized doctor yourself, so what is something that you've learned over time?
When I was as a postgraduate, I used to learn with my seniors. I used to interact with them. Then see how the surgery has been done. I used to ask them questions, then go to the library immediately and see what exactly is the stuff in there. So at that time, the Google, you don't get so much of thing in Google. So we used to attend a lot of conferences. Try to increase your knowledge. Upgrade your skills. Then go to a surgeon and try to learn from them. Then I was in my senior residency, where again I had this opportunity to work with globally renowned orthopedic surgeons, right? A surgeon called Whiteside from US, one surgeon from Russia who used to come on a monthly basis to Sai Baba Hospital. So from there, initial hiccups were my surgery time was much more. Like if there is a simple fracture of the thigh bone, I used to take around 1.5 hours of stuff. And initially, because there's no one to around and you need to do your surgery. I still remember my first surgery where I was very much worried, tensed. I had the knowledge, I had already 5 years of experience behind me, but that was a surgery where I was doing all alone. Any time, any given point in institute, whereas in Vaidehi or in Puttaparthi or KGH Hospital, Andhra Medical College, you have a senior, at least who's not in the operating room, probably in the hospital or somewhere nearby. So if something happens, that you can definitely call him. So that was my first surgery where obviously no one. Even I've done surgeries, I've never called my seniors. But the thought will be there, right? At the back of your mind, someone is there for help. So that surgery, I thought it will take long, but God's grace, I completed 1 hour. So from there, I have learned many tips and tricks which you operate and you learn from the patient himself. The fracture pattern, no fracture is same. Even if it occurs in the thigh bone, I have operated multiple thigh bone fractures, but no fracture is the same. No fracture is the same. The pattern is different, the approach is different, the patient height is different, patient bone architecture is different. Depending on the age, it changes also. The choice of implant is different, right? So then I used to upgrade my skills by going for these conferences, workshops and everything. So doing that, my surgical time has reduced a lot. So initially I used to post anesthesia, stay in the operation theatre, positioning of the patient. Probably others don't know, you feel like fine, operator, surgeon goes, just puts his knife, puts everything inside and comes. No, it doesn't happen that way. So it takes a lot of time. First there is anesthesia, then we wait for 10 to 15 minutes, then we put the positioning of the patient according to the fracture. Then we scrub the part, make it sterile totally, that takes around half an hour. Then we drape the part using all sterile clothes, that takes another half an hour. Then we start the surgery. So after the patient is shifted into operation theatre, it takes around 45 minutes to 1 hour to start the surgery. So everyone feels like, patient is taken in, it's been 1 hour, the patient is not coming. No, we don't start the surgery immediately. So this is the protocol which we follow. So once everything is done, then we start the surgery. So from the starting to ending, it might be half an hour. But it is portrayed to others like, it's 2 hours, the patient is still in the operation. No, it doesn't happen that way. So it's just half an hour or 1 hour job. So initially I used to do all this stuff, position the patient, then do the scrubbing part, supervise the draping and everything, and keep all the instruments ready. So all these years now we have evolved. I have taught my juniors, we have made some senior resident and fellowships. Now it's like they know everything, the anesthesia is given, I'm sitting in my OPD, so then they put the positioning of the part and they drape it and everything, then they call me. Now it's like I just
so you outsourced most initial
because that's how it happens. So initially I used to do the job. In my post graduation I used to do everything ready. Then I call up my chief. Someone called, sir, chief, everything's ready. You can come and start the surgery. So then I did it myself, for me itself. Now in these years, that job I have given it to my juniors, where they'll do all the initial stuff. Then like everyone feels, I just wash, put my gloves on and take the knife and start the surgery. So yeah, it is difficult. So my advice to all juniors is, immediately once you complete your postgrad, don't go into practice and don't run after money. Try to upgrade your skills. And orthopedics is very broad nowadays. It's not like only a fracture or stuff. Trauma is a different aspect. Joint replacement is a different aspect. Arthroscopy, ligament repair is a different aspect. Deformity correction is a different aspect. Hand surgery is a different aspect. Tumor bone oncology is a different aspect. Right? So, and pediatric orthopedics, different aspect. So choose your profession. Even after your orthopedics, you need to specialize in one of the specialty. That's how it works. So my sincere advice, if you're practicing in a city like Visakhapatnam or Delhi or Bombay or Bangalore, you need to choose your orthopedics post MS, the specialty, the specialty. Even though there is no special degree for that, but things have evolved a lot. So now you need to exactly choose something in orthopedics, so that I'll do only joint replacement, probably knee and hip. Yes, you do trauma, that's not a problem, but you need to again specialize in that, so that you'll stay with the tide, exactly what exactly people are doing, the best of the job you need to do, and you need to learn a lot. And then come back and put the same thing into your practice. It takes time, but that is fruitful. That's how it works. Doing everything, probably it won't work in major cities over here. You need to be very specific about what you do. And I tell my juniors always, read before you come for a surgery. What I used to do, even till date, before going for a surgery, even I've done it multiple times. I again go through the approach, the surgical approach. The tips and tricks of doing the surgery, how to reduce the fracture, how to do it properly. Then even there are a lot of stuffs available in YouTube also. There's something called Ortho TV. There are recorded videos of all major surgeons, which is just available in just on your phone. You can just check into it. You did not go anywhere. Once you know how to deal with a fracture, all the patterns are available. Just go through them once, go through the journals once. So every time I go for a surgery, I feel okay, fine, this is the first surgery which I've been doing. So that really helps a lot. Even if you have done n number of surgeries, again brush up your topic. Basics. Brush up your basics. You will never end up in a problem.
So doctor, what is the most challenging surgery that you have performed till date in the history of your career, and what particularly about that made it very challenging and complex to handle?
So there was a patient, a 9-month pregnant lady, right? Full-term lady, first pregnancy. She had a fall at home. Then she had a fracture of her thigh bone. Fine. To make it more complex and worse, the bone which was fractured already had a tumor in that. So the bone was weakened by a tumor. She was a 9-month pregnant lady. She had a fall at home, and she has fractured the bone through that bone tumor. Now this makes it very challenging. You need to deal with the pregnancy. You need to deal with the bone tumor. You need to deal with the fracture. Now even in history, if you look at the articles or rare cases, people do publish all around the globe. They publish, this was a patient where was a pregnant and they had a fracture. There are few cases reported in history where there was a pregnant lady, probably a road traffic accident has caused a fracture of the thigh bone. But never in a 9-month pregnant lady with a bone tumor. So this was a rare case, not yet reported in history. Probably I'll just make an article of that case. So this lady, I had to deal with the pregnancy, and then I had to deal with the fracture and the tumor also. So it makes very critical for anesthetists to do the job. So we had I used to work in Apollo Hospital at that time. So I spoke with the gynecologist, I spoke with the anesthesia, I spoke with the critical care team, the pediatrician. So everything we kept ready. So now the problem is, do we need to deal with the pregnancy first, then the fracture, then the tumor, or the tumor and the fracture first, then the pregnancy, then the child? So because never a case has been reported, so you have no guidelines set to that, right? So then we all together sat together, a pediatrician, a gynecologist, myself, intensivist and the anesthetist, then see the pros and cons of the procedure, what can be done first. So it was decided, so that because she is a full-term lady, ultrasound was done, the baby was fine. So it was decided the first the baby will be out, first we'll take out the baby, right, through cesarean. So then the challenge was the anesthesia in this part. Okay, once the baby is out, there will be imbalance of things and the anesthesia gets deep. So I had to do the fracture as fast as possible. Okay, because I cannot keep the lady in anesthesia for a longer duration. So the baby was out, baby was fine, pediatrician took care of it. Then I positioned the part, then I had to go in, remove that part and pieces of tumor. Luckily the tumor was a benign one, which we call it doesn't spread or something. It looks like the same on the X-ray. And even the baby, the lady was pregnant and the 9-month-old baby, I could not get a CT scan also done, because that will be harmful for the baby itself, because CT is like huge radiation. Okay. So then being the features were of benign origin, so I went in, I removed that bone thing from there, the tumor, for biopsy. I fixed the fracture. So the biopsy came as a benign tumor. It's not a cancerous one which spreads and stuff. So 6 months after that, I see the baby was fine. She was also fine. She was walking. They're from Parathipuram. They came after 2 years with the child just to thank me. Very healthy child. I have a photo of them also, the baby and the mother, father and his grandparents and myself. That was a challenging case, and I'm really happy. Till date I remember them, they remember me. It was quite a challenging case, never reported in the history previously. So it took a multi-mode approach, a lot of doctors' involvement in this, and successfully we could manage the pregnancy, the fracture and the tumor. The tumor came out to be benign, so it was fine. So there is a nail inside the bone. Probably we'll take it out after 1-2 years from here. It is totally healed right now.
Okay. So how long was this?
This was around 6 years back.
Okay. So she's still having the nail, or like?
Yeah, she's having the nail.
Okay.
So I've been asked, I've told her, by 3 years we can get it done. She's just waiting for a sweet time. So let's see. Let's see.
So doctor, also, so what are the most common fractures do you actually see patients coming with, and what do you think are the causes and of the most common fractures? Like, let's say 90 to 80% of the cases, something I think you'll come across the fractures or.
Yes.
So what is the most common and the reason why that's happening, and how do you usually recommend people to deal with it?
So to start with, the initial days of my practice, probably 15 years back, 14 years back, it was more of road traffic accidents.
Okay.
Nowadays there is a good awareness. Traffic police are very strict. So generally you wear a helmet, you are careful. Okay, head injuries have come down a lot. Previously I used to see fractures with head injuries, brain injuries. Now that has drastically come down, right? So nowadays what we see is more of a domestic falls.
Okay.
An elderly male or a female, okay, late in the night and early in the morning, fall in bathroom, okay, having a fracture of the hip or the wrist. So generally if you fall at that age, you fall on your hip or you try to keep your hand. So they fracture their wrist or fracture their hip joint, hip bone. So total fractures, of all the fractures, 80% is of the hip and the wrist itself. Okay. So the highest recommendation is, when you are elderly at home, see to that you have anti-skid mattress all over, especially in the toilet also, and see to that there are door handles in the toilet, so that if they are tending to fall, they can at least hold on to some of the door handles and then not have a fall. So these are the very frequent fractures which we see. The road traffic accident fractures have come down a lot. There's a good awareness amongst people. Many people are wearing helmets, or you need to pay a very hefty price for that, hefty fine. So these fractures, especially the elderly, you can cut it down by using this anti-skid mattress, keeping a wheel walker at home, and having door handles. Yeah.
Got it. Also, doctor, so with the rise of, a lot of blue collar jobs, right, and white collar jobs, I think now people are just very towards the work from home, or they're just working let's say 10 hours, 12 hours in their office. And I think the rise of the desk jobs over the decade has grown exponentially.
Yes.
Right. Yes. And what are the reasons and also the consequences besides the new health stuff that's actually happening because of the desk jobs, and what would you recommend for them? So what are the usual common challenges that's coming with the desk job particularly, because I think more than half of the population right now is just
doing
stuck. Even if it's not the population, I think even the kids right now are just stuck to the PCs, laptop, or gaming stuff, and are just sitting over entire, I think, half of their life. So what are the health things and consequences that's happening because of that, and how would you treat that as a surgeon yourself?
So what you said is absolutely right. People who are having a desk job, they tend to sit for longer durations. The screen time is more. Okay, so their sunlight exposure is less. Okay, which is very vital. Vitamin D is very vital for stuff. And they have weakness of their muscles. Okay, because they don't tend to move, don't tend to exercise and stuff. So a lot of young patients, what I see, they all are having bone pains.
Okay.
Early fatigue. They say after probably a day's work, I'm totally tired and stuff. Then what do you do? Desk job, and you're tired, fatigue and stuff. And they say I have a back pain, neck pain and stuff. So these are very, very common. Now the problem is sitting for longer duration is not good for you. Okay, so because everything is borne by your spine, when you try to sit, the whole load of your body, upper body, is on your spine. And when you do have a desktop in front of you, you tend to go into the desktop, you don't keep your neck straight. There's something called ergonomics. I've delivered a lot of talks in WNS, in the pharma companies, especially the desk people. The company people always call me, sir, please give a talk on ergonomics. Ergonomics means workplace posture correction. So always remember, if you sit for half an hour to 40 minutes, keep an alarm. So after 40 minutes, try to get up, stretch yourself, and then you can go for your desk job. Keep your neck straight. Don't peep into the desktop. See to that your neck is at this angle. At 30 degrees you'll allow, not more than that. When you sit, try to sit straight. Your posture should be this way. You should not stoop forwards. This is very bad for your spine. Okay. Then you need to have a lot of sunlight exposure. Okay, that's really inadequate, especially in the people who are doing a desk job. They don't expose themselves to the sun. So when I say sunlight exposure, your face is not good enough. Probably your arms and legs should be exposed. The surface area should be more. There is no particular time, like morning, early morning, afternoon. It doesn't work out that way. You can anytime, any point of time is fine. So people who are having a desk job, you need to have exercise program on a daily basis. Okay, see to that you get adequate sunlight exposure. Vitamin D rich foods. Okay, you know that vitamin D, it's not present in vegetarian plants or stuff. So more available in egg yolk and fish and stuff, right? And more from the sunlight. Okay, so you should have adequate sunlight exposure with adequate surface body to be exposed to the sun on a daily basis. Work out on a daily basis. If you cannot work out, at least have a brisk walk of 3 kilometers, which is mandatory on a plain surface, not on a tar road, or keeping an inclination of 3 to 5 steps in your walker or stuff. No, that doesn't work. Okay, on a plain surface, 3 to 5 kilometers of brisk walk daily, exercise, sunlight exposure, vitamin D rich foods, protein diet, and following the ergonomics in your office, sitting straight, seeing to that your neck is straight, trying to get up after every half an hour, 40 minutes. That will see to that your this fatigue issues, the backache issues, neck pain issues will come down. So my advice to all these people who are doing a desk job is that you do this on a regular basis, or else I see all these IT company fellows coming to me having a neck pain, back pain, fatigue. Vitamin D is essential for your bones, your muscles, your well-being, right? Your immunity and everything. Okay, so once they come to IT person comes to me, I said first get your vitamin D done. Okay, and astonishingly everyone it's low. it's not even insufficient, it's deficient. The normal value is 30, it will be around 6, 7 or something. It's terribly low. So what happens when you have low vitamin D? You tend to get early fatigue. Okay, you tend to get these bone pains and muscle weaknesses, and the bones become brittle over course of time. With a trivial fall also, you might fracture your bones.
Okay.
So that's the importance of vitamin D, and keeping your muscle and bone health checked. So yeah.
Right now, what I also see in my family as women and all, right? So women experience a lot of knee joints and pain, like knee joint pains, right? When compared to men, is it statistically true that women actually have more of like knee joint pain compared to men? And what do you think is the reason behind it? And when we also talked about the lifestyle diseases, right? So how, like while we already have like a lot of women working in offices and all of that, and a lot of our, let's say, mother and grandmother and all of these women, they stay at home, and they tend to have these like knee joints or the foot joints, right? Like the pains over there. So why do you think that happens more to women when compared to men?
Yeah, to specifically answer your question, because women after menopause, there are hormonal changes.
Okay.
From menarche to menopause, there are some hormones in the body. Okay, after menopause in women, generally men don't have menopause, right? So after women have menopause, the hormones, something have stopped, some hormones are not there. So generally they tend to go into osteoporosis. Now what is osteoporosis? Loss of bone architecture, right? Okay, so it is not seen in men at an early age. Okay, in women probably after 45, 46 they go into menopause. The bone becomes weak because of the hormonal imbalances, right? Then generally they have more stresses on the knee joint because we walk on our limbs. So hip joint and knee joint takes a lot of stress. So post menopause, all women after 45, 46, they'll start experiencing this pain at some point of time, probably 60 or 65 or 70 or something, right? So it's very important to take care of them. Even WHO recommends women after menopause, they need to get their bone density test done, a DEXA scan or a BMD, a vitamin D and calcium. Then they need to get supplements on that. If not taken, the bone tends to become much more weaker. The joint goes into arthritis, and they require a joint replacement surgery. So what is said is absolutely right. Yes, statistically women have this problem more in women, especially the knee joint problems and the hip joint problems and everything. That's because of the menopause and hormonal changes which do occur, right? To counter this, so after you get to your menopause, or you have some other diseases like rheumatoid arthritis, increased uric acid, which is again more in women, rheumatoid arthritis, you need to check with your orthopedic surgeon. Okay, get your test done. If there is any deficiencies in that, try to look into those deficiencies, work out on them, so that your bone strength is regained again. So even if you fall, it won't get fractured for a trivial falls, right? So in men, probably after 60, 65, these changes occur, osteoporosis and arthritis. So whatever joint replacement surgeries we do, they're more in women. Even they work at home, and even they don't have a hard work, they don't go for outside work, still it is women who suffer a lot, right? Especially with the knee joint pains. What you said is right. So I tell after every woman, you reach a point of menopause, try to consult your gynecologist or your orthopedic surgeon, get your bone being tested, the bone mineral density, and try to take the supplements on a regular basis, and whatever I've spoken about, vitamin D and calcium and your protein intake, so that you stay healthier. Okay, or else definitely your joints are going to wear and tear, and once they go into wear and tear and go into stage 4 of arthritis, then replacement is the only option left for them. Okay, so and something called fracture rate reduction. Okay, even WHO follows that. So once you categorize the women, after a certain point of time, you do this test and you mark them as osteoporotic, then they need to be treated aggressively with something called bisphosphonates, calcium supplements, vitamin D supplements, phosphorus supplements, so that the bone strength is regained. Or else with a trivial fall, they tend to fracture the bone, and if the osteoporosis is continued for a while, the knee joints go into arthritis, which is irreversible. It's a progressive disease, and probably after some point of time, it becomes so severe that they'll have this crossed knees. The bent knees. Then they have a duck walk and stuff, and the pain is severe altogether, ultimately requiring a surgery. Okay, so what you asked is right. Women tend to have a lot of bone pain. It is statistically correct. True.
Yeah. So when, as an orthopedic surgeon yourself, right, like if you have to recommend top 5 exercises that you would, you would recommend your patients or anyone, let's say if only these 5 exercises, if this person is doing for the rest of his life, he'll be like, at least in a good shape when it comes to the exercising point of view. So what would that be for you?
Yes. First, I'll start with the neck. Okay, try to keep your neck straight. Do your neck rotation exercises to the sides, to the back, and to the front. Then coming to your back, you need to do your back extension exercises. Okay, and do your legs on a regular basis, because your calf is called as the second heart. Okay. So probably people who go to the gym, they might know, there is never a day without a leg day. Okay, try to do your leg exercises daily. Your shoulders, especially your shoulders, keep them as supple as possible. And other people who are doing these desk jobs, especially them, keep your neck straight, back straight. Do your back strengthening exercises, your neck strengthening exercises, your shoulders well. And in elderly, so you cannot do all this kind of exercise which requires a lot of physical strength. A brisk walk of 3 kilometers is good enough.
Good enough.
Yeah, a brisk walk, not normal walk. Normal walk doesn't help you. Okay. A brisk walk of 3 kilometers is very good. And you can do this simple stretching of your neck, stretching of your back, stretching of your legs, and back extension exercises, keeping your posture correct. So this will definitely help in them. So keeping your neck in a proper shape, keeping your back in a proper shape, and keeping your shoulders. Generally with age, you tend to get cervical problems, neck problems. Then people get back problems more commonly. It's not like a young or elderly, it is the same in everyone. Then you tend to get your shoulder issues, especially in men with diabetes. They get this something called as frozen shoulder. Okay, you keep your shoulders fine, rotating daily. So these exercises will see to that even if you have a primary cause like diabetes or something, you will not require any major treatment to be done. So once you keep your joints supple, everything in movement, especially your spine and your shoulders, you're good. Probably with the primary treatment you'll get off.
Yeah. So also, doctor, given the stats, with immense culture of the junk food, and obviously the Swiggy and Zomato has obviously came to the rescue for the last minute munchies and midnight stuff and all of it. I think correct me if I'm wrong, but today's youth, I think, is going through a lot of the health issues when compared to, let's say, 2 decades ago of how our fathers were, right? And if this keeps continuing, what do you think would happen, let's say, next decade when, no exercise is just being done, or maybe the food habits is something that almost everyone is guilty of, even sometimes me, where I'm like, okay, let's stick to a particular diet, but that's not going to happen more than a week, and then some party comes in or some invitation comes in, or maybe that you're very tired to even cook at that point of time, right? So let's can you help me show how's the other dark side of this continuation of thing looks like, particularly for youth?
Yes. So what you said has already started. The vicious cycle has started. So people who don't exercise, don't have a proper meal and cook food, and they have junk food, I've seen them having these back pains, neck pains, cervical problems. Okay, even probably you would have seen young patients having cardiac issues also. 30 years they're having cardiac. Yeah, that's also one of the reasons. You don't have a lot of stress, have junk food, a lot of stress, no proper sleep, no proper meal plan. So going forwards, your bones will become weak, your muscles will become weak, you'll have early fatigue, irritation, a lot of screen time, you don't exercise properly, right? You don't meditate, okay? So going forwards, I see that, all these muscle pains, bone pains, and bones become weaker. Even the next generation, they'll also tend to be weak, because you're not accustomed to a proper healthy lifestyle.
Exactly.
Our elders, grandparents, they used to work in the sun. Most of it was cultivation, right? Previously, grandparents probably, that was the one major profession were into farmers, right? So they used to have the meal at probably 7 or 8 or 9 in the morning, a good strong meal consisting of ragi, java and all this stuff, properly cooked food, and they used to sleep at probably 8, 8:30. You go to, nowadays you go to villages, by 9 o'clock you don't see any house having a light inside, probably they don't. I mean, interiors, it has spread to villages also, where people see a lot of YouTube and they have all this stuff. So if you don't change our lifestyle, okay, the bones will become weaker, your health, you will have a lot of health issues, cardiac issues also, okay, the stress will overcome you, and that's not good. That's not at all good.
Exactly. And also adding to this, we have also seen like a lot of rise in diabetic patients, right? And that comes also with the arthritis. So how does a diabetic patient manage or prevent arthritis to happen?
Okay, right. So having diabetes and arthritis is a double combo. Okay, so there is some diabetes which is hereditary, that you cannot stop. Okay? Ultimately it will come to you from your parents or your grandparents, hereditary stuff. Okay, so people who are having diabetes, they need to have a proper meal plan. Check with your diabetologist or the physician, get your medicine straight, have your meal which doesn't have all the sugars and stuff, do exercise so that your joints are fine. If you don't exercise and your diet is not restricted and your medication is not proper, so what will happen? Diabetes will cause something called diabetic retinopathy and diabetic neuropathy. Okay, retinopathy, your eyes, they'll get this thing called something called cataract. Fine. And neuropathy, it has effect on your neurons also, where patient will have the sciatica pain, tingling, numbness and stuff. And even your joints will not be healthy. They'll go into arthritis. Okay, diabetes itself is not a disease actually. Diabetes will see to that your life is ruined. Okay. Diabetes, you have diabetes, you get an injury, it won't heal faster. You have diabetes, you get an infection, it won't heal properly. It spreads a lot. Okay, you have diabetes, you get a surgery done, it doesn't heal, the skin doesn't heal properly. Okay, so diabetes complicates everything. Okay, so the worst disease to have is diabetes. Okay, so once you have diabetes, see to that it is every time under control. Have a check with your diabetologist on a regular basis. See to that your HbA1c is below 6. Have a proper meal plan. Do a proper exercise so that whatever second things come to diabetes will be under control. Once diabetes is under control, all of the stuff tend to fall in place. You don't complicate it much more.
Got it. Yeah. So what would be the top food choices that you would recommend as a doctor yourself, and you have seen people, just going wrong with the food choices and everything? Let's say if I can eat just only 5 to 6, we cannot say that, but like 5 to 6 must have food in your diet without any, without otherwise talking about. So what would that be? So these are the things that people must and should include. On top of that, whatever that goes. So what would that be? Food choices.
So first of all, you need to have protein.
So when you say protein, what exactly do you mean? So
it can be plant-based protein also. There are a lot of vegetarians.
Not that. So when I say protein, I think viewers might think those big boxes of protein powders.
No, not protein powder. Protein powder is for muscle building and stuff. You can have ragi. Okay. You can have ragi, which has very good amount, much amount of it. You can have dal also, which has good amount of protein. Then you can have non-veg. Egg whites, especially egg whites, have good amount of protein. I generally don't tell my patient to have mutton. Okay. Because that meat, the uric, some people, the uric acid tends to become more, and they'll cause joint problems. Okay. So egg a day is really good. Even you have NECC, National Egg Coordination Committee, rose cow and Sunday Hoya Monday, rose cow and day. Even government promotes that. It is true also. The white has protein and the yolk has vitamin D. Okay. The protein is must. Whether it's vegetarian or non-vegetarian, try to have protein. Then try to have fiber. Especially in the evenings or in the night before, because the digestion will be easier. Okay, the protein, the whole day when you're working, you'll have protein so that you'll have your energy levels well. Fiber in the night so that you'll have a good digestion. Then coming to the meal plan, try to stick to a 2-meal plan. Okay. 2-meal plan, that will be better. The major part of the day where you work, say probably from 9 to 4 or something, try to have a good breakfast in the morning. Okay, because your main work is over there, right? Try to have much more. If you are relaxed in the afternoon or stuff, then skip your lunch. Try to have some sprouts or some fruit. Have a fruit. Okay, try to have a fruit and close your dinner as early as possible. Say I don't say before sunset, yeah, probably 6:30 or 7, whenever you feel like, but by the time you sleep, everything is digested and nothing turns into a fat. So have a properly cooked meal, okay, don't go for junk foods, right? Have protein in your diet, which is important, either plant-based or animal-based. Have eggs, egg yolk especially, sea fish, which have good amount of vitamin D. Then have fiber in your diet and have a fruit every day.
Got it.
And others, it's up to your choice of yours. Probably Jains have some other thing. Probably other people, they have some, you cannot have onions, you cannot have these also. So it depends on their preferences. So check your diet plan. See to that you include protein into that, some fiber into that, and some fruit into that.
So doctor, out of your tenure of obviously serving right from the, let's say, from the MBBS part and to whatever you're working right now, so what are the latest technological advancement in orthopedics that actually happen where you have seen the major recovery and majority, like great outcomes in the patients? So let's say whatever is there right now, or whatever that was added right now and that was not there a decade ago or few years ago, so what are those things that were added so that actually helped in the drastic recovery of the patient, according to you? So what are these?
I'll answer it in phases, right? The first came the joint replacement. When I was in my post-graduation, it was new. People used to do joint replacement. Then at that point of time, it was only a manual joint replacement. It has evolved in a very huge way. Okay, those times we are using metal on metal. Okay, especially we are using cobalt, chromium, and stuff alloys. Then came zirconium into place, which is a very good metal. Then came ceramic into place, which have longevity, huge longevity of the implants. Wear and tear rates are very high. The technique of joint replacement has changed. Previously we used to cut the whole tendon and go in and do that. Now we go around the tendon so that patient recovery is faster. Day one they are able to kick their knee. Then you can extend the knee. Extend the knee. Especially the implantation has evolved a lot. There's a lot of R&D in joint replacement. What I have seen previously 15 years back, it was a basic version of joint replacement with the implants, and the implants availability was also less because everything was manufactured overseas and we used to import that stuff. And the knees which are present, patients who are there in US and UK, so implants were made according to their knees.
Okay.
Their general height would be around 5'10", 6 or above 6, right? And an Indian female 5'2", 5'3", average height, right? So those don't fix to our knees, right? So we used to get a lot of confusion, Sometimes the implant used to be very huge. Even you go for one size, the minimal size over there, probably a 1 mm overhang was there. Now we have something called persona knees. We take a CT scan, we design according to your knee. And get it done. So it perfectly matches your knee. Okay. Now we have knee replacement implants manufactured in India with that Make in India promotion. We have a plant in Ahmedabad, one in Bombay, one in Pune. Okay, where they match the Asian knees. So the Asian knees are different from European and the people staying in US and stuff. So now we have these implants. The diameter of size of the implants have come down a lot. Right, so this is one major change which I have seen in the metals and the approach what you see. Then coming to the surgery aspect of it, now today we have we had computer navigation in between 4-5 years back, where the computer navigates us to do the surgery exactly, to look at the exact amount of bone to get the proper alignment and stuff. Now we have a robo which previous day it takes a CT scan, it shows how much amount of bone to be resected, how much to be released. Your size of the implant is also decided even before going to the operation theatre. Once we go into the operation theatre, we open the joint, then direct the robo. Once we say everything is fine, it starts chopping off your damaged bone. Then we keep the implant and come out. Here the precision is very high. So we have automated robo, image based, interactive robo. Okay, in between if I want to stop, I can stop it. There is a screen which is available. Okay, I feel there's something needs to be balanced. I need to upsize, downsize. I need to cut less on this side, cut more on that side. Whatever I want to do, I can just command the robo, it will be done. Now people always, some people ask me, okay, fine. So the robo is doing all the job, so you'll be sipping your coffee. Probably would have got. No, it doesn't happen that way. It doesn't happen that way because I command the robo.
Okay.
I guide the robot. The robot doesn't guide me.
Okay.
I guide the robot saying that, okay, fine. Once it is done, I say, okay, fine. Cut it this much, angulate it this much. So there are a lot of complex geometries in the knee joint. Knee joint is not simple. It's not like simple movement happen this way. Okay, fine. You cut it above, cut it below, everything. No, it doesn't happen. It's a 3-axis movement, X, Y, and Z axis. So I need to balance it very properly, right? So in robo, previously, if a patient have a severe bent knee, we used to remove a lot of soft tissue on the inner side, see to that we get it straight and stuff. If the patient knee comes in between 1 and 2, we used to compromise for either 1 or 2, because in between you don't have 1.5.
Okay.
Right? Yeah. And we used to release a lot of muscle around to get the knee straight. Here, the robo, we have planned it the previous day. Okay, it does the exact amount of cut over there, 1.2, 0.5, 0.7, whatever, whatever exactly the amount is to be cut, it does that, so that it is highly precise, and the release of the tissues is less, so that rehabilitation is very good. The second day patient is walking, and third day we discharge the patient.
Okay.
So that has evolved a lot. This regarding replacement. Regarding arthroscopy, previously people used to have this ACL and PCL injuries, especially athletes. Okay, so in the initial days of my MBBS, it was an open surgery only. There was no arthroscopy where you put a microscope and try to do everything. So it was just evolving at that point of time. So now it has evolved in such a way that we can just, with the help of a microscope and one hole, where we use the instrumentation, we can repair the ligaments, can remove the damaged cartilage, whatever is there. Even in shoulder injuries, with a minimal 2-3 punctured incisions, just a simple stitch over there, we are able to do a lot of arthroscopic work, just micro holes over there. Then comes your advancement in especially non-operative treatment, something called orthobiologics. Okay, it was not there previously. Now we do a lot of PRP injection, platelet-rich plasma. Okay, where you take your blood and centrifuge it and activate with platelets. Then we have something called bone marrow stem cell therapy. Okay, we take some of bone cells, bone marrow from your iliac bone, your pelvis bone. Again, we centrifuge it and remove some of the bone marrow from there, inject into the joint without any surgery. And nowadays we have something called stemmer injection also, which is already processed bone marrow, which is commercially available. Just need to come, just take in the operation, nothing, no suture, nothing. Just take a small injection, poke it into the knee joint. Initial stages of arthritis, these people tend to do well. So these are all the advancement in the field of orthopedics from which I have seen and which I am here today. And much more is there, much more. There is much more coming up, much more coming up.
So just a very out of the box question. So let's say when the other fields, let's say the software or like being a marketer or salesperson or the engineering, with the rise of the AI, a lot of people from these fields are kind of getting scared. What if they replace your job one day?
Yes.
So when AI is coming into the picture in medicine particularly, do you really think that it's going to be a threat for doctors, or are the jobs of doctors going to be replaced by the robo? Because now that you said that you need a doctor to actually guide the robo, let's say if there are 3 doctors that are being involved in the operations, so you could have one doctor and then robo, I guess. So will that actually happen, or do you think is there any threat for doctors' job going into the future, and compare when AI and ML, machine learning and artificial intelligence is coming into the picture, particularly in the medicine field and also the orthopedic field?
So pertaining to desk job and other IT stuff, I have very less idea, but I think probably AI is replacing a lot of jobs. Then to answer your question, I have attended AI workshops. Okay. People are innovative in doing this AI work, especially in orthopedics and medical field. Trust me, you cannot replace a surgeon. No AI can replace a surgeon, because the surgeon knows where exactly the bone has to be kept, how exactly it has to be reduced. It is a programmed machine. Like I said in the first half of our interview, every fracture is a new fracture.
New fracture,
Even if it happens at the thigh bone, the same level, every fracture is new. Okay, every bone is different. Every individual is different. Okay, his height is different. Lifestyle diseases are different. Okay, his bone architecture is different coming from his family background. So I have attended a lot of conferences. I am a member of some AI Orthopedic Academy also, right? So trust me, no, AI cannot replace a surgeon. It cannot. Yeah, it definitely can help us Okay, help us do the better outcome of the patient. Like I said, in a robo is a programming device, right? We take a CT scan, it shows this angle, this is how I correct it. Then I need to say yes or no. Okay, so I'll just tell you a small thing what has happened in a robo. Once I put the input in the robo, for the correction, for the something called tibia bone, which is right behind in the knee joint on top of the femur bone. So to correct it, it made the angulation of tibia into 6 to 7 degrees of varus, this angle. Okay. No, this is not acceptable.
Yeah.
Now the robo is making it into 7 degrees just to get your knee straight. But the robo doesn't understand, if you keep this angle like this, it will cause a lot of wear and tear and pain to the patient. And it should not be cut in this angle. Okay. Only a surgeon knows that, you should not do that. You should compensate that somewhere else. Okay. Now coming into artificial intelligence, okay, same, it works as a robo, okay, where it can guide you. But can robo go and operate no, it cannot happen. Even for a robo, first I need to open the joint, remove all the tissues around, keep it everything open, then input the robo to come and cut the whatever, to do the precision of the cuts, right? Even AA comes into picture, AA will say the same thing, okay, just guide you. But can AA operate? No, it doesn't happen that way.
Yeah.
So there is no threat for surgeons. Yeah, for physicians probably, if you input your symptoms, if you put your symptoms, probably I have a cough from these days, and probably I have my family history. There'll be a set of questions. My family history of diabetes, or I have rheumatoid in the family, or hyperuric acid. Probably leading to your questions, it will suggest some blood tests for you. Then once the report comes, probably it can suggest, take this medication and stuff, if they are certified. Okay, so there is a minimal threat for the general physicians, okay, but surgeons, no.
No other field of medicine that can actually get, have a little probably threat by AI. Let's say physicians could be one of them.
Physicians could be one of them, because you did not go to a physician. You just input your symptoms, say that this is there, then probably it will suggest you some blood tests or some x-rays. Now you get this home x-rays and home blood tests, right? Someone will come and collect your sample. Then again you will input those tests over there. Probably AI might it is also helping. It will help you know what medication you can take and stuff. Again, so there should be vast knowledge inputted into the AI, right? What is an AI? AI is again it is made from human brain, right? You input all those data. This medication will have these complications. This problem will, the symptoms should be this. This medication should be used. This medication has this side effects. Patients having this diseases should not use this medication. Now everything should be incorporated, and it should generate a logical reasoning from there, and then it should prescribe the dose.
Exactly.
Right? So again, if something goes wrong, if something goes wrong, now you cannot criticize the AA. But probably making initial diagnosis, it might help the physician. Okay, if a patient comes with symptoms, probably you can input your symptoms. You might be given a tab, put your symptoms over there, what you are allergic to, right? Or checkbox, what are the the checkbox, what we do before we see the patient, especially the physicians. They check your blood pressure, right? They check your pulse rate. Okay, they ask for, my junior asks for if you have any other diseases, diabetes, hypertension, any disease in your family. Probably that can be skipped and everything, so that once they come to the physician, everything is ready. So then you can come to a diagnosis and prescribe your medication. But surgeons, no. Because surgery, how can a AI do a surgery? If something goes wrong, there is something called anatomical variance. Okay, every muscle does not in the same place as you and me. Okay, it differs. Okay, there is something called artery, popliteal artery, which supplies the whole of your limb. Okay, it might be 1 centimeter to the left, 1 centimeter to the right. Sometimes it might be thin, sometimes it might be thick. Right. So how does AI know? Okay, so if at all doing a surgery, if it takes everyone into the picture, generalize this thing. Okay, he says, okay, this thing will be 1 centimeter here and there, then I'll cut till there, so it is a safer margin. But what if you have anatomical variation and your blood vessel is more towards the left side, and then it just goes and bashes into the blood vessel, then it is a catastrophe, right?
Yeah, exactly.
Even if you incorporate the data, so again, you need to go through a lot of tests, CT scan, that angiogram and all this stuff. But as a surgeon, we know, okay, fine. You need to look at this area, acha, there is anatomical variation, the vessel is somewhere over here. Because we have knowledge, we have studied, okay, we have gone into the practice, we have evolved over all these years. So as a human brain, I can understand, okay, fine, there is something here, that is a vessel, it has to be on this side, but in this patient it is on the other side, which is a common thing. So then I will try to accustom accordingly. So no, A cannot replace a surgeon. No, it doesn't. You can just guide the surgeon, help the surgeon.
Yeah. So doctor, looking into the future, what do you think is the biggest breakthrough in the orthopedic surgery and how it's going to transform over the next decade? So how would the orthopedic surgery future look like according to you?
Okay, so I've seen a model, okay, in one of a national conference where there was a young surgeon, fine, he has done a surgery, his experience was less. So it failed ultimately, okay. So there's a person, a doctor in Canada who's developed this software. So that had to be reoperated. So again it has to be planned. So what this surgeon, the senior surgeon has done was done the software, developed the software. He could get all the CT of the patient and how it can be planned in a software. And it was shared with well-renowned surgeons in Australia, one in India, probably one in I guess he's in Mexico. Okay, so on a real-time basis, they made a flow diagram of that. Okay, how best it can be reduced. Okay, through a IR vision. Okay, in the real time, all the surgeons were connected with the young surgeon in the operation theatre. Okay, was doing a surgery. So it was previously planned what to be done. So they were giving their inputs in between the surgery. Okay, and how best the implant can be positioned was decided already through a CT scan, which is a real time also. So the surgeon there, which the initial surgery, it took him around 2 to 2.5 hours. This resurgery was done in 1 hour with the expertise of all the surgeons throughout the globe.
Oh my God.
With the surgeon operating in operation theatre, he was connected to 3 of the other surgeons from around the globe, and he could do the surgery well. And the time was shortened. It would have probably taken 3 to 4 hours or something, because being a resurgery, in the span of 1 hour it was done with the expertise of the best in the field.
Yeah.
Okay, so that was a rehearsal kind of a thing. It was not a problem. Probably this kind of a softwares will be developed. This kind of interactive things will be developed, where if you are having any issues or any problems, so you can post your case in that software, and you can take help of it. So the other surgeons who are best in the field probably might guide you in the operation theatre how best you can come out of the surgery and how fast you can do, so the results are also better. So that is one aspect which I am looking at. And there was a doctor from UK, Royal College of Surgeons of England, where he is working with the Queen. Okay. So he's trying to develop a medicine where by giving a simple injection into the joint arthritis will be reversed. The joint will probably become normal, pre-arthritics. Even if you get in stage 3 arthritis, which is just before the stage 4, stage 4 is the end stage. Probably it will change the whole architecture, and the normal cartilage, whatever is there, it can be regrown with just a simple injection. So that is being developed. So fingers crossed, probably we can see all this in the future, and having this awareness of your bone health and diseases, and there are a lot of knowledge available online, offline. So I think people will get healthier. Okay, and this lifestyle disease will come down. Okay, post COVID, I think most of the people have concentrated on the health, their fitness, and everything, right? So going forwards, it will definitely increase the surgical time, give a better result to the patient, and we can see a lot of advancement in that stuff. Yes.
Got it. Also, doctor, just the last few questions where, let's say, every non-medical person, let's say, before, so when it's actually serious, from the Indian mindset, we just don't rush to doctors until it gets out of hand sometimes. And sometimes it'd be like, okay, let's do that gharelu nuske, all the whole remedies and all of it. And most of the time, I think my generation or, our generation, what we do is Google it. And then half the time we'll be panicking, seeing the symptoms there. And then, so what is your take on that? Where is that really helpful for someone who does not not have a medicine knowledge to blindly trust any blog or the Google searches, or what would you recommend people should do before like they come to doctor and something, and how to handle it?
See, for simple things you have a solution, right? If you have a common cold or cough, you have a crocin available, you can see the ads also previously. You have a paracetamol for fever and stuff. You get a lot of over-the-counter medicines in India, right? In other countries, developed countries, they don't give over-the-counter. You just tell him, I have a headache, I have a fever, I have loose motions, he'll give you medication, right? Which is not allowed in other countries. So even the pharmacists in India, you know, they are very careful of giving other drugs. If you ask for some sleeping pills, no, he won't give it to you. Even with the prescription, sometimes they won't. But in developed nations, if you have a prescription, they'll just bombard you with the medication. Here, they're very careful of giving those medications. So for the initial things, you can Google it up, you know, for a headache, small back pain or something, or you can just go to the medical store. That is a better thing, because he'll see to that, you know, you are not overdosed or something. Okay, but yeah, mistakes do happen because he's just a pharmacist. He will not take your clinical history. What is your previous history? Are you allergic to these drugs or not? Right? So probably a very less percentage will be allergic to diclofenac. Someone might be allergic to paracetamol also. Someone will be allergic to penicillin. Okay, so the pharmacist should ask you, which he will not. Okay, so Googling up is very bad. Okay. You Google up, if I just type a simple back pain, it will start from a muscle cramp to a cancer.
Cancer, exactly. Every Google search, ends up in the cancer thing.
Because see, that is a differential diagnosis, what we call. It might be. Unless and until it is ruled out. So that is up the surgeon, that's up to the doctor's headache, to rule out things. A simple headache is a headache to the physician. You know that a simple headache is a headache to the physician also. A headache might be a cluster headache might be due to stress, due to dehydration, due to some tumor in the brain, due to some other thing, due to diabetes, due to overworked up, sleeplessness, all this stuff. So that is up to the physician to diagnose it, why is that problem, what is causing that problem. So if a patient comes to, we don't say that, get your whole body scanned and then we will see if there is any problem. Right? It doesn't happen that way.
Exactly.
Some people just give medication, some will ask for some blood tests, some will ask, okay, go for an MRI. Others, where you feel they will not respond to this kind of a medical treatment, we ask them to go for a surgery. So my suggestion, never Google it up.
Okay.
If you have simple problems, take your home remedies, go to a medical store for simple issues. Probably will help you, because even if I say it is wrong, I should not say that go and take medication from medical store. But it is well tolerated. If you in Visakhapatnam or you go to rural parts, the pharmacist is the biggest doctor out there.
Exactly.
Isn't it? Even a RMP, right? So chalta hai. Till there it is fine. But don't Google up. If you Google up, if you type one symptom, it will go on, the search engine will show you multiple things. Then you are totally screwed up. And then people come to us saying that, no sir, I have Googled up and this is what. Immediately get a CT scan, immediately get an MRI, immediately do this test done. So you are unnecessarily burdening yourself. When you go to a doctor, please tell your symptoms. Please tell your symptoms, please talk to the doctor. So let him decide. So if you feel like, okay fine, please get an MRI done, fine. But if you say that it might be a cancer, get it done, that doesn't sound good. Even the doctor is bothered about you, right? If he feels that you have a cancer, he'll get the workup done. So don't try to Google it up. Over the count to an extent is fine, because nowadays you can online prescriptions are available. You can just upload it and you can get your medication doorstep. That is also fine. But more than that, Googling it and taking medication, no.
Okay.
It might be a catastrophe.
What according to you is the worst nightmare of a doctor coming alive? What would that be?
Okay. Any doctor for that sake, might be a physician or a surgeon, losing a patient's life is the worst nightmare. Okay. We tend to operate. Luckily in orthopedics, we don't have so much of morbidity. We don't lose patients because they are mostly planned surgeries. Even a fracture is a planned surgery. Unless and until it is open fracture, it is exposed to the external environment, or there are some other comorbidities causing the problem. There we tend to lose a patient because they'll have multiple trauma, chest trauma, abdomen trauma. Along with that, they'll have fractures.
Thank you so much, doctor, and it's been like amazing information that I got. I think I would not actually get all this by any YouTube or Google search myself unless I'm talking someone with the first-hand expert on the ground himself. And it was really honor, and I really had like great time listening to you, and I hope you enjoyed sharing your journey, which is really inspiring to me as well. So, yeah.
Thank you so much for having me. It was great, and your questions were very nice. I hope it is useful for the general public.
Definitely, yeah.
And I'll definitely charge you for the professional fees for all the advice what you give. Thank you so much.